Hello, everyone. Good afternoon, everyone, and thanks to the Alliance for having us today. So my name is Kaylin Frolkus, and I'm an academic hospitalist here at Metro Health, which is a teaching hospital for Case School of Medicine. And I'm so excited to do this. I hope we get to the real bulk of this will be the workshop. But in preparation, we'll give you some background. So with me today are some of my colleagues. My co-conspirator for this project is Jillian Michelson. And Jillian, you can see here, I'll actually go ahead and go forward so you can see some pics. You'll see them in the in video. They'll leave their videos on so you can chat them separately. Jillian and I came up with this project using the assessment and reasoning tool for faculty and for residents. And we had such good feedback. We were hoping to sort of see what we want to share, what we've done, but ultimately really get a sense of what you all are doing in your institutions as well. With us also is Dr. Jane Barr. She's the head of our clinical competency committee in the internal medicine residency program, and a local reference for all things assessment and feedback related. And then Dr. Marianne Reeves, who's the head of our clinical medical education practice here at Metro. So for any med ed questions, she is our resource. So just maybe obviously we have no financial or other disclosures to disclose. And the objectives for today are to get to that workshop bit, but we'll do a little bit of review about clinical reasoning, defining it, sort of reminding all of us why we do academic medicine and why assessment and feedback is so important for our learners, for ourselves, for our society. Using particularly this assessment of reasoning tool, which I will thus sort of from here on out refer to as the ART. That is what we used here. I get no payment, I get no reimbursement for using it. I just really liked it. And I've been a member of the Society to Improve Diagnosis in Medicine. And so I have had a little bit of faculty development around it as well, but again, interested in what you all use. And then we'll break out into groups to actually practice using it and apply it to real learner cases. So clinical reasoning, some of you here today will be able to define it more beautifully than I. It's sort of ever elusive. How do we do what we do, and how do we describe what we do? For all the reasons that we want to describe it, so that we could do it better, so that we can teach it better, and obviously today assess it in a more defined way. So it's making sense of, it's synthesizing, it's sorting through patient sort of data, patient stories, lab and test results. And the last quote here by Gruppen in 2017 is the longest, but I also like it the most because I think it does a nice job of talking about the relationship that needs established between the practitioner, the clinician, and the patient, and how much that hinges on our knowledge, which of course is experience, biases, what we've seen recently, heuristics, and how we ultimately come to define the problem. But it focuses also on that revision bit, which is so important and has become so important to my teaching and to my practice, which is being nimble, right? Staying vulnerable, staying open, that the data I ask for may not fall nicely in line with what I think is going on. And a lot of that ability to finalize a problem is based on my own threshold of confidence. Like how confident am I in my workup so far? How familiar a territory am I in? So these are sort of the things at play, right? What we know, what we bring to the table, our patients and their information, and then how we define and then revise that problem so that we can ultimately get to diagnostic accuracy and then getting our patients better. I'm sorry if you can't see that. Yeah. So this is a diagram from Durning. It's a relative, 2013 article where they discuss all of the different things that are at play in a clinician-patient interaction. It talks about sort of the cognitive theories, lots of psychometric theories that are not my expertise by any means. But I like how it brings clinical reasoning and the diagnostic process out of this black box, which is like this solitary, individualistic process, and sort of focuses on how interrelational those two-headed arrows are so important to notice. Like it's a give and a take, and a lot of things have to go right for us to be successful at this. And I would say a lot of things have to be made apparent for us to know how to fix it if it doesn't go well. And I put that star there so that I remember to say, this is about assessment of learners, right? So I've been talking a lot about what we do ourselves, but at the end of the day, our learners are being dropped into this melee. And if we're going to be able to give formative feedback and help with their clinical reasoning development, having a little bit of empathy about all of the things at play, I think is an important place to start. So some basic tenets. What do we do? So we gather data, we generate some hypotheses, a lot of subtitles there, a lot of bullet points could fill that space, but a lot of that is based on communication. How curious are we? Are we asking the right questions? Are we pivoting when things don't go our way? And then how are we defining the problem? What sort of differentials do we come up with? And of course, that is rife for our own biases, our own experience, our limitations of knowledge. We don't know what we don't know. And I had a wonderful teacher who once said the scariest time in a patient's life is when the clinician makes the diagnosis, right? Because what happens? We stop thinking broadly. We start sieving everything through the diagnosis we have made. And then hopefully we come up with a leading diagnosis and a workup that follows, with the goal of a management and therapeutic plan for our patients, right? So what do all of these bullet points have in common? They're all fertile ground for error and for missteps. So the point of this is really just in my own practice, I've started to reflect on what is it that I do in a patient encounter so that I can be cognizant of what I need to improve on, where I'm weak, so that I can better explain to my patient what I'm doing and why. And then ultimately, as an academic hospitalist, how can I better give feedback to my learners so that they too can get a sense of what we do in the clinical encounter and where we can improve. So the Delaney article talks about teaching clinical reasoning by making thinking visible. And I just love the idea of that. And again, that is a 2014 article, but there was a wonderful article, 2022, the Jagannath article about the cognitive apprenticeship, which is sort of along the same lines, which is thinking out loud and showing your own thought process can really help your learner reflect. I think sort of a nice parenthesis here is, if you're thinking aloud, you're being vulnerable to them, right? You're saying you don't know everything, and you're sort of also navigating through all of this information in a more transparent way. And the assessment of reasoning tool is what has helped me use a vocabulary that is easily shared with learners, so that you have like a shared model, shared vocabulary when you do sit down to give feedback. Ultimately, for yourself, for your learners, and then for your whole system, potentially community, as you all get better at diagnostic reasoning and diagnostic accuracy. So assessment of learners, and this I wanted to turn to Jillian, who's been active in this project, about like, why do we care?
Yeah, so thank you. And I think we talked before about how this article that was published by another medical student referencing the idea that learners really want to be assessed is a really important point as part of all of this, because the assessment and the thinking out loud from the perspective of the practitioner can kind of show a vulnerability, as you were saying, and it also can help the learner like understand what's going on a lot more thoroughly. But also, I think learners, like from the medical student perspective, come into the clinic not knowing that we don't know what we're doing yet and wanting to be better so that we can be the best doctors we can be. And not getting kind of the feedback and the assessment and like the critique to do better is a real impediment to that success and that journey. And so like learners are asking for this. And this article is kind of about comparing how in music and music education, there's a big focus on sort of very specific criticism directed towards improvement, and how hard that can be in medicine, given kind of the personal relationships at play and just the perspectives that we have on developing a shared vocabulary for having that productive criticism. Beyond, to the next slide, maybe. Beyond kind of just the perspective of the learner wanting to improve and asking to be critiqued, we know there's public health research looking at how practitioners in their future careers practice the way that they're taught, which feels sort of logical, but also I think is we were talking about, is so important to recognize, because when a practitioner does not kind of honestly critique the learners who are working with them, that person is going to go on to not understand the errors that they made or understand how to improve their skills. And that ends up having implications for patient quality, safety, and care, like cost of care down the road. And if without kind of discussing what's happening, all you have are people who are going to practice just like the person that they learned from. And so when that conversation, kind of all that thinking can happen out loud, it can end up helping both parties kind of improve and understand the reasoning behind what they're doing, not just the specific like actions, but like why, when is this appropriate, and how to be kind of better practitioners. And even like more than all of that, I think we also have seen from the National Academy of Medicine, formerly the Institute of Medicine, that there's significant, this is a project that the National Academy of Medicine has been publishing on since 2000 and earlier. And in 2015, their report said that diagnostic error can lead to as many as 80,000 deaths in the US, something that could be mitigated with kind of a focus on effective teaching of how to do diagnosis. And the ACGME now specifically includes clinical reasoning as a core competency in Milestones 2.0, kind of just reaffirming and continuing to demonstrate how important that skill is and how large an impact it can have when it's really kind of purposefully taught and intentionally taught to learners.
Yeah. And so, we know this, we've known this for a long while. So why don't we do it? Or maybe why aren't we more comfortable with it? I would say in my own case, I didn't feel particularly well trained about this. And all of us say lots of different things when it comes to this, right? So time, just how busy we are. It's hard to carve out good time. Sometimes I would say even on rounds, you feel so stressed. Are you listening well enough to really give them nice focused feedback on their assessments? The longitudinal relationships, again, so truncated these days in our division. Some of us only round or rotate on the floors for 1 week at a time, right? So how are we supposed to really build those relationships to create a confidence where the feedback helps or is even listened to, right? And then it's uncomfortable, right? I'm sure there are other feedbacks, and in the small groups we'll hear what some of your the barriers to your giving more formative feedback is, or to your ability to assess clinical reasoning is. But for me, I also lacked a schema. I didn't know there was one, to be honest. And so I went through some time sort of developing, okay, what should I be looking for? The Dreyfus and Dreyfus model, right? So the novice, that's to becomes the expert and the teacher. And I love, this is from the web, forgive me, but I love that the expert teaches, period. And they're sort of on autopilot, right? Which is like that's the worry, that I'm going to go on autopilot and not realize how many errors I'm making now that I'm the expert and the teacher. So, but this is, obviously something we're all pretty familiar with. The rhyme is obviously very well used and well respected. The reporter that then becomes the interpreter, the manager, and the educator. And I do use this a lot on the floors, because it seems like when you're listening to a presentation, it can be quite obvious that this learner is reporting a lot of data without that interpretation, without that synthesis. The mini CX, and pardon that slide, that should be larger, but the mini CX is also a tool that can be used right at the bedside with a learner. And I will get some feedback from you about how you have used that in the past. And then this is the ART. So the assessment of reasoning tool is what, and we'll link this in a few slides so that you all have access to it along with the QR code. And Sheila will email this to you so you have like the original article, etc. But the assessment of reasoning tool, potentially at first blush or first glance, you're saying, no, thank you. It's so wordy. It seems so maybe bulky. But this is what I have used because I've liked the really focused way you can use it. So for example, it has 5 domains. You can focus on 1 or all 5. You can read it before you round as a reminder of the kind of vocabulary you are listening for, and then give feedback. You could sit down with a learner and do it all after they present. So you can use it in a variety of different ways. We here at Metro have used it as faculty development, sort of similar to the workshop we are about to do, and with residents, also similar to the workshop that we will do, so that everyone is working as an assessor of the learner. But we've also used it for the medical students so that they will, there are linked videos on the CITM webpage, so they can look at the videos, and then we can go through a learner case so that all of us are sort of on the same page using the same vocabulary. So the point of this workshop is that every time someone presents to you is an opportunity to listen for their clinical reasoning skills. And the more we sort of generate a vocabulary of assessment and clinical reasoning, the better our feedback will be. And obviously, the hope is that as we get better at giving feedback and get better ourselves, the domino effect will be, a public health sequela. So this is the tool, and this is the original article from 2018. There has since been a validation article that was published, and Sheila will send those out to you, those links. And so this is a QR code, or you can take a screenshot because we will be using these in our small groups. So I'll give you a couple minutes to do that. And Marianne actually just posted it in the chat for everybody as well. Okay. So the agenda for this next, say, 25 minutes is Sheila's gonna break us up into breakout rooms. We will all hear a learner's HMP. And the idea here is that you are going to be listening. You're not gonna be able to read. It's as if we're on the floors listening to a learner. And we're gonna go through just those first 3 domains of the ART together with the learner, assigning a level of completeness, but with the specific task of trying to formulate feedback. And again, some of you will be better at that than others. It's not that this is the only way to do it, but a lot of this is about sharing practices. So we'll share what works for us, what we do in our institutions, and then we'll come back in 25 minutes to rejoin the bigger group and go through those together and sort of share some important points, things that worked, things that didn't, insights, etc. All right. All right. Hi, welcome back, everybody. I hope that the groups were, am I still sharing? Let me make sure. Hold on. I hope you guys had some good discussion. We definitely did. So I will share, we'll get back to it here. I want to hear how you guys all assess the learners. So for this first domain, this was the hypothesis-directed data collection question. Jane and Jane's group, where did you guys assess? Where did you think they were after this presentation?
Yeah, so our answer for the group, we actually, made it more minimal, although, we saw some aspects that may have been partial. So we sort of stuck it sort of in the middle, but we were leaning more towards the minimal.
Okay. And our group also said minimal. We didn't say partial. I wonder what was partial for you? What parts of the presentation?
This is Gurpreet. I can add. I was in Jane's group. Yeah, I think we were probably mostly on the minimal side too. I think one of the things you recognize that listening is hard, and sometimes when you're listening, you're like, "Did I track every detail?" And so, like, there was questions about maybe there were some things that were mapping onto a potential diagnosis or not. But I think the weight of our feeling was minimal. That it wasn't questioning wasn't tied to specific things that were had in mind. It was just a rote collection of data points.
Yeah, and actually, I think Lou, you mentioned, like, does the learner know that those data points were important or not? So that was why we said minimal, because we weren't sure if, like you said, it was sort of tracking, and we weren't sure how much it was affecting the differential at the end of the day. So we scored minimal. So this is the step of, did your learner follow a logical course? And do they give you clues? Sort of, I think all of us, when we hear a presentation, are listening for the things that support where they're guiding you. And if something doesn't fit, it's usually presented in such a way. So, this sounds so much like seizure, alcohol, which also the thing that doesn't fit, but we didn't get that from this presentation. And then what about we didn't get here because we were talking about other things, but for problem representation. So this is when you sort of, did the learner ultimately describe and define the accurate principal problem? Did you guys get here, other group?
Yeah, we did. And we came up with minimal.
Okay.
It was pretty transparent that it was minimal.
So the questions here for problem representation are sort of, did the learner clearly state what the problem is? And our learner said that he came in with a fall, which is good in that we're keeping things open, right? Like in our group, we talked about, is this syncope? Was there loss of consciousness? Is this seizure? But it might be too broad given some of the data that he's given us so far. So here's where you're looking for, did they synthesize relevant findings? This is when that sort of medical jargon comes into, that can be helpful. It's not a necessity, but things like acute, persistent, intermittent, those are the sorts of words you're listening for here. And that you really get a sense that the learner knows the patient, has recognized the relevant findings, the time course, et cetera. And then for the last bit is, did the learner prioritize a differential? And though we didn't give our learner a score, I think we all mentioned that she, our learner, they did not. There was no can't miss discussion. What about your group?
Yeah, I'll let David maybe chime in, or
I can chime in. Oh, there's David here.
We found that there was no prioritization, really no discussion about can't miss diagnosis. So we scored it at minimal.
Okay. Does anyone from my group, we didn't talk specifically about this. Again, we sort of got lost in other discussion, but did anyone want to weigh in from the other group? Mai or Carmen or Jessica or Lou?
It did seem like he just listed a bunch of possible things without prioritizing them at all. So I would have put minimal as well.
Okay. And so here the prioritized bit is you're really getting the sense that they're ranking things. And with some justification, like again, it can be, this is what supports, this is what doesn't support. I want to do this first, making sure I sort of reconsider or consider these other entities based on those results. All right. Well, so in the effort to, again, I'd love to hear what you guys are doing in your institutions, but for us, I feel like this has definitely helped me talk about what happens sort of at point of care when you're listening to a presentation. It's helped us focus on sort of more formative feedback. So let's get some feedback. Lou, you raised your hand. You're muted though.
Thanks. I have a question about where in the schema of the ART is the concept of physiologic thinking. In other words, a lot of this has to do with pattern recognition. The student's representation seems to be something bad happened and he landed on the ground. And the differentials seem to be syncope, maybe as a vascular event, seizure as a metabolic neurologic event, and fall as a mechanical traumatic event. What I'm not sure is where in the schema does some idea of accounting for the physiology, or the pathophysiology has to be put together. In the pulse and the blood pressure being high, there is no fever. There are transaminases and there's a lactate problem. Right. So where is that in the ART? Is that hypothesis directed to explain the physiology? Is it problem representation and how you describe the problem? That's what I'm not clear, what I'm trying to learn about.
So I'm not sure that I will be able to answer the question. I mean, Gurpreet might be the better responder, but I would say that if you're listening to someone give you a presentation, you are also getting a sense of what they're finding. For my practice, I feel like I can hear what they have found important to help to what they have found to be important to bring up to the problem, right? So how they define the problem should be based on the data and should be based on what they learned from the patient and their examination of the patient. And so if it's not adding up to me as a listener, that might be where I say, wait, what do you make of the heart rate? What do you make of the blood pressure? And I guess I would also say, I'm not sure that any schema will allow me to have a similar conversation about the pathophysiology to someone else who has a different, different experience or different medical knowledge or a broader diagnostic schema at their fingertips, right? So I think I can only do as much as within my own limitations as an assessor. That would be how I would answer that.
Okay.
I don't know if Gurpreet.
Thanks.
Yeah, and Kaylin, I agree with you. I think there's no specific stop in the ART for sort of pathophys. So where one would make the inference on it is either the evidence they make for and against their sort of competing hypotheses. You can make a judgment about whether they brought pathophys into their syncope differential or not. There is sometimes after they represent the problem and before they jump into the differential diagnosis, we don't have it here on the ART, but you can ask people, oftentimes too, to say, please tell me your schema.
You froze.
Can ask them to say, can you give me a one-liner on how you think through syncope? And oftentimes that does clarify what their pathophysiological
Reasoning might be, or what might be the mechanisms of the seizure if you were thinking of seizure.
Precisely, yeah. So you elaborate sort of your broad take on the whole problem before you dive into your specific one.
Wynn, I think you had a question.
Yes, a little bit of a different question, but curious what you think about sort of extrapolation of this tool outside of the clinical setting to use it for example, an OSCE, and as we think about kind of other ways, if it could be used in the not only that sort of formative at the bedside, but do you see any kind of practical application for this kind of in a summative realm? I'll just give an example. We use an OSCE that in the third year that does include a problem representation. After seeing a standardized patient, we do a problem representation and a structured reflection tool that does create prioritized differential and supporting refuting elements and sort of next steps in management. And to me, this seems like a nice way to kind of potentially mesh that for not quite a rubric, but just curious if you think that there's anything that you all have used in that realm at all.
Anyone? I can wait to see what other people have done.
I'll just say I use it only in a formative per moment. It's episodic per clinical encounter. I haven't used it in OSCEs, but I think OSCEs, because they're end of one episodes, I think they're equally suitable for it. Just because I think you wouldn't say that someone's scoring in one situation versus the other. Like even we were talking about in our group, like a senior resident could do marvelously on one patient in the ICU and then flounder or struggle with another patient and score differently, like in the clinic, or if they don't have global health rotation. So not the thought that sort of a couple snapshots would be a report card on clinical reasoning. I know we're hoping for that, but I think this is meant to be more episodic.
Thanks.
Yeah, I sorry, go ahead.
I was just going to say, I think, OSCEs are a useful way to use this tool just to provide, some feedback to the learner in a different way, but more focused on these various domains.
Yeah, I haven't either used it in like a simulation. But again, I have used it sort of like as a tool, even for myself, like before I listen to a learner. So it could be helpful if you're like the assessor or the rater. Okay, we have 2 minutes left. This is from this ACGME workshop I did, but I just think it's such a wonderful quote, that feedback is for our learning, not great, you did great, you mastered that, which is, sort of to speak again, sort of what Gurpreet was saying about that the learner that does marvelously one place, the next patient, and I think for ourselves as well, that it will change. So giving feedback can help know where we are so that we can continue to improve. All right, so selfishly, we would love a survey. So if you can do the QR code and give us some feedback, we would love your feedback. I appreciate everyone here today, and thanks for your participation. Does anyone have any other thoughts or questions for the group?
I know I didn't get to finish with my group. We were starting to talk about, using the assessment of reasoning tool as a way to segue into giving the learner, feedback. We talked about, instead of using the feedback sandwich type of technique where you give positive, negative, positive, to actually use the art as a way to do more of an ask, tell, ask, or more of a self-reflective type of approach to feedback. And, always framing the feedback to the learner as I'm giving you feedback. And which I think is always important, being prepared. And I think using this tool allows for that preparation. And then also doing it, as immediately as you can, and in a private area. But I really like, using the art as a way to ask the learner, giving them to self-reflect, what did they identify as their observations on their presentation, and then, then flipping it to where, what they've done well, but then teaching them, and discussing plans for their improvement. And I think the assessment of reasoning tool, really allows for that.
Right. It is 4 o'clock. Thank you all for being here. Email us with anything, and we'll email you.
Yep.
All right. Thanks.
Thank you for a very fine session.
Yeah, that was terrific. Thank you, everyone.
Good. Well done.
Thank you.